Good afternoon. If public health estimates are correct, 88,000 Canadians will succumb to illness and die in the next 12 months, not from coronavirus or COVID-19, but from the planet's oldest healthcare nemesis, cancer. And yet, with so much of the world's attention and healthcare resources devoted to fighting COVID-19, it's easy to forget that cancer patients continue to rely on life-saving treatments and that cancer researchers remain key soldiers on the front lines in the age-old battle to find better therapies and eventual cures for many of the diseases we call cancer. And as we will learn during our time together today, some of the recent advances made in cancer research, including some of the experimental therapies newly developed for the fight against cancers, could wind up providing us with a crucial understanding in the battle against infectious diseases such as COVID-19. Welcome to Cancer in a COVID-19 World, the latest in our weekly series of McGill alumni webcasts. My name is Derek Kassoff, Managing Director of Communications at McGill's Office of University Advancement. It's Thursday, April 16th, and I'm delighted to be joined today by three of McGill and Montreal's leading cancer experts. Let me introduce them. With us, we have Professor Morag Park, Director of McGill's Rosalind and Morris Goodman Cancer Research Center, the Diane and Sal Guerrera Chair in Cancer Genetics, and James McGill Professor in the Departments of Oncology, Biochemistry, and Medicine. Welcome, Professor Park.
Thank you.
We have Dr. George Zagopoulos, hepatopancreatic biliary and transplant surgeon at the McGill University Health Center, associate professor in McGill's Department of Surgery and Oncology, and a scientist at the Research Institute of the MUHC and the Goodman Cancer Research Center. Welcome, Dr. Zagopoulos.
Thank you, Derek.
And finally, Dr. Sarit Assouline, a physician at the Jewish General Hospital, Division of Hematology, senior investigator at the Lady Davis Institute, and associate professor at McGill's Department of Oncology. Welcome, Dr. Assouline.
Thank you, Derek. Hi.
Hi, and thank you all for joining us today. So before we jump into a discussion about research that's taking place in our hospitals and our science labs, and the synergies between cancer research and COVID-19, which I find quite fascinating, I'd like to get a bit of a sense of what things are like right now on the clinical side and how cancer patients are being impacted by the COVID-19 pandemic. Perhaps we'll begin with you, Dr. Zagopoulos. Can you tell us what the situation is currently like at the MUHC for cancer patients who are currently receiving consults and treatments? I imagine that patients are potentially at a higher risk of infection, given their already weakened immune systems. So what are physicians and hospitals doing to protect these patients when they visit hospitals and clinics to receive treatment?
So, Derek, why don't we start off with new patients that have a new diagnosis? Because I know a lot of patients have had anxiety about, they've now been diagnosed with a cancer, and will they be treated or even seen by their physician? So the answer to that is we are continuing to see patients. We have adapted to COVID-19 measures, and most of our initial visitations with patients are through phones or Zoom teleconferencing. If we feel that the patient needs to be seen in person, then a safe visit is arranged with the patient to be seen in clinic. In terms of treatments are continuing with patients. We have balanced the risks for continuing treatment with the risk of delaying treatment. So patients where we feel the cancer is aggressive and does need to continue to be treated, those patients continue to have their treatments. The same holds true for surgery. We are continuing to offer surgery to patients that have a cancer diagnosis. Again, the emphasis is on balancing safety for the patients from a COVID infection and getting them through treatment, whether it be with chemotherapy or other biologic agents or surgery.
Okay. Dr. Assouline, I'd like to maybe turn that same question over to you as well. You're obviously practicing at the Jewish General Hospital, which has been designated by the Quebec government as one of the province's main COVID-19 response centers. So how are physicians such as yourself at the Jewish General balancing the safety of cancer patients with the health implications? And are you relying on more remote options or telemedicine in some cases to try to deliver consults and treatments to patients who need it?
Right. So I want to echo some of what George said, which is that we are maintaining and continuing to give the life-saving therapies that patients need. What's changed a lot is a lot of our follow-up visits are now done remotely through telemedicine. So I would say 3/4 of patients no longer come to the clinics. We call them at home to see how they're doing, and then we judge whether they need to come in for a blood test or a face-to-face visit. This has allowed us to, honor or respect the social distancing rules. So our waiting rooms are now spaced out so patients aren't sitting side by side. We are scheduling blood tests at fixed times so people don't line up at the blood drawing room. And we try to ensure that patients don't wait around too long to be evaluated by their physician. So it's radically changed the way we care for patients.
Mm-hmm. And how are you addressing patient fears? I imagine a lot of cancer patients are simply afraid to go visit a hospital right now.
Right. So before any patient comes to the hospital, we go through our clinical lists, and either we or our secretaries call the patient, ensure they don't have symptoms that could suggest that they may have COVID-19. And then we explain to them that when they will come in, there will be very few people in the area, that they have a set time, that we have measures in place to ensure proper infection control for them. So most of them are reassured. Most patients, I'd say, particularly those who have symptoms that they're worried about, want to come and see us. And so, reassuring them that we've controlled the environment for them makes them feel a lot more comfortable.
Mm-hmm. So I do want to actually maybe turn to a couple of questions pretty early on here, because we did receive several questions from alumni about the clinical aspects of care. And we'll probably direct these questions again to our two physicians. Dr. Park, don't worry, we have plenty of questions around cancer research coming up shortly. But let me start with the first one, which is a fairly broad question. It comes in from Philippe Capeliez in Ottawa, who asked, at this particular stage of the pandemic, what are the most pressing concerns of oncologists concerning the treatment of cancer patients? Dr. Zagopoulos, you want to maybe jump in on that one first?
So I think what's important is to recognize what cancers have to continue to be treated versus those that could afford a delay in treatment. So the most aggressive cancers are the ones that we do not want to see an interruption in treatment, balancing, of course, as I mentioned earlier, the safety for patients with respect to their risk of getting COVID-19. I think that's really how the framework of making treatment decisions has been implemented here and from what I know across other centers. Sarit, as a practicing oncologist, maybe you could address that better than I can, and we could come back to the surgical management of patients.
Well, that's exactly right. We're ensuring that those patients who need their chemotherapies to sustain life, to prolong life, are getting them, but we're just trying to sort of reschedule things in a way so that the clinics are safe for patients. A lot of the therapies that are given, we're trying to change some of the infusional therapies to oral therapies. For example, in multiple myeloma, some of the therapies that we give by injection can also be given orally. So we're trying to change treatment paradigms in order to reduce the number of people sitting in our infusion clinics, for example. So we're trying to do the best we can while respecting the social distancing rules.
Mm-hmm.
Eric, if I could come back to that last point, just to reassure folks that, in giving patients oral therapy, so therapies that can be taken by mouth, those decisions are taken considering the evidence of efficacy or how good these pills by mouth are versus intravenous medication. So we're making those decisions cognizant of potential differences, and where there are strong differences between the two, we'll obviously try to stick to the better therapy for the patient. So I just wanted to reassure folks.
Yeah, that's absolutely correct. Sometimes the oral therapies are better, but we haven't used them for questions of approval and cost. But yeah, absolutely.
Mm-hmm. So there are two more questions I just want to get to, and it sort of makes sense to get to them right now because they speak, I think, specifically to what you are both referring to, the sort of balance between delivering treatments but keeping patients obviously safe from infection. I'll leave out the names of the questioners, obviously, for confidentiality reasons. The first one here, somebody wrote in asking, why is surgery for aggressive thyroid cancer in a 30-year-old male postponed 2 months? If it is aggressive, then is there not a chance it will metastasize? Then we will have even more problems, and it could then become life-threatening. Obviously, you can't speak to specifics of that case, but Dr. Zagopoulos, in terms of like those kinds of aggressive cancers, is it okay to wait a little bit under the circumstances?
So it's hard for me as a pancreas liver cancer surgeon to speak to thyroid cancer at this point in my career. But if we take a step back, when early March came along and we started implementing these measures, we were all very uncomfortable. And initially, the reaction was to delay for the week or two all surgery, perhaps, until we understood how this pandemic would unfold here in Montreal and in Canada. As time has gone on, we've understood the pandemic more. It also gave our institutions time to implement safety protocols for both the patients and the healthcare workers, and we're doing more and more surgery. The way it's been managed at my institution, and a lot of effort by Dr. Leanne Feldman, our surgeon-in-chief here, and the entire leadership, has been to put together a committee. And that committee consists of the individual department heads from the various surgical groups, as well as an ethicist, and taking recommendations and directives that have come from the ministry. And every week what happens is this group meets and looks through all the urgent cancer cases that are waiting and makes decisions, and which cases need to be operated on more urgently versus others. I could tell you that of all the cases that were submitted last week at the MHC for cancer to be operated on this week, slots for these operations were found through all of this work that has been done by Dr. Feldman and her entire team. So we are prioritizing, and we're in these prioritizing decisions. Patient safety comes into consideration, and we do consider both the safety of the patient in getting COVID, as well as the safety of waiting to do the surgery a couple of weeks later, or sometimes a month later, versus going ahead now. And of course, this has to be balanced with healthcare resources and anticipation of a potential surge. As time goes on, we have a better sense of what the COVID surge stands to be, and we adjust accordingly.
Okay, great. Well, I think that's a very good answer, and a good way to explain some of the challenges and the balancing act that's being played out in the healthcare system right now. We did receive several more questions around the same idea, including some pertaining to pediatric cases, which I know nobody on this panel is comfortable addressing specifically cases around pediatric cancer. So I think the guidance there to people is to obviously consult directly with their physicians. And if we do have time towards the end, I will want to return to some of the other questions that came in. But I do want to turn a little bit now to the whole issue around cancer research and bring in Dr. Morag Park from the Goodman Cancer Research Center, director of the center. So let's begin, Professor Park. I'm curious about the state of cancer research during the pandemic. Everyone's attention obviously seems to be diverted to different health concerns. Maybe you could start by just describing to us a little bit how many professors, researchers, and graduate students are typically engaged in research activities at McGill through the Goodman Cancer Research Center, and what has happened to their projects and laboratories as we practice physical distancing and take a pause from all but essential services. Is cancer research considered to be an essential service during a pandemic, or are things have ramped down on that front?
Yeah, that's quite a long question. But at the moment, at the Goodman Cancer Research Center, we have over 300 researchers and trainees at the center. But across McGill, including the teaching hospitals, there's over 700 researchers and trainees that are involved in both fundamental as well as translational research on cancer, focused on cancer. At the moment, we're at the university and we follow the guidelines from the Quebec government, such that for social distancing, but also to ramp down and only conduct essential research services. So at the center, much of our research is actually put on hold. However, we are able to come in and support essential activities. And many of these include preclinical models that are actually developed from patients' cancers. And our questions, and we use these to answer questions on why these individuals respond to treatment or why they fail to respond to treatment. So these are unique resources and are considered essential to support the studies on these.
Mm-hmm. Thank you for that update. Now, we obviously don't know when life will return to a more normal situation here in Quebec or elsewhere in the world. But do you anticipate, Professor Park, any delays or difficulties in ramping research back up to normal levels once the all clear is given to return to work?
Mm-hmm. Well, even if we could all go back to work tomorrow, it will take at least 6 months to get back to where we were before we started to ramp down. Obviously, they won't open the doors to everybody, and there'll be a slow ramp up. What I can say at the Goodman Cancer Center is that we're already planning how to build up the ramp up, allowing a subset of individuals to come in and start the really key experiments that will take a long time to build back up.
Okay. Well, thank you again, and hopefully the delays won't be as long as we fear. And so I'd like to maybe talk a little bit. I find this really fascinating, talking about some of the parallels between cancer research and the research taking place right now to discover treatments and vaccines for COVID-19. So I understand that a COVID-19 vaccine is centered around harnessing the antibodies we create to protect us from coronaviruses. I also know there have been significant advances in recent years in understanding how our own immune systems might be our greatest weapons against cancer cells that are ravaging our bodies. So maybe I'll stick with you, Professor Park, to begin this section. But what have we learned about our immune systems and how they work within the framework of cancer research that might be applied to our ability to fight off COVID-19?
Yeah, I think I should start with COVID-19. And, what we see in the majority of people is that their immune systems are sufficient to attack the virus and essentially eliminate the virus. So what that tells us is that if we have a strong immune system, that's sufficient to eliminate this virus. However, sometimes our immune response may not be strong enough or even swift enough to reverse the spread of the virus in the body before the onset of disease. And this is what we see with the progression of the infection of the lungs in a number of patients. And so preventative vaccine is designed to essentially prime the patient's immune system and to build a memory within the immune system such that if an individual becomes infected, they can detect the COVID-19 and they eliminate it before it really progresses and leads to disease.
Okay.
So vaccines are often raised, to the surface components of the virus, and these are the bits that we see sticking out in all of these pictures of COVID-19. But, we can now really draw the parallels with what we've understood, in cancer. And building on research from viruses in the last 60 years or so, there's been intense research in the last 20 years to try and understand how the immune system can be used to also attack cancer cells. And these discoveries, which gave rise to the Nobel Prize in 2018, have really transformed how we now treat cancer. They've led to what we now call immunotherapy type drugs. There are multiple different approaches. Some are aimed at just stimulating the immune response in the host immune system to attack the cancer cells. And so these therapies have revolutionized cancer treatment as we know it now. They fundamentally changed the outcomes of certain patients that had previously hard to treat in advanced cancers. Some of these are melanoma, some lung cancers, head and neck and bladder cancer. So these approaches are based on what we've learned from virology and other pathogens, but can also lead us to understand a lot about how individuals respond, for example, to viruses such as COVID-19 that they haven't seen before.
Mm-hmm. Great. Do any of our physicians want to jump in as well? I know that you obviously are practicing a lot of these immunosuppressant therapies, perhaps with your patients? And are you also seeing those parallels between the challenges around COVID-19 and some of the work in oncology and cancer?
So I'd just like to add that in oncology now we are using drugs that actually are immunostimulants. So they encourage the immune system or encourage the immune system to recognize the cancer, because the cancer has tools to evade immune response from the host. So our therapies are, many of them now, are to wake up the immune system so it can fight the cancer. And that's how virus vaccines work. They stimulate the immune system so that when a person is exposed to the virus, they already have an immunity and they can fight it. The problem with COVID-19 disease is that if you've missed the opportunity, if you have been unable to fight the virus with your immune system, then the virus can later cause your immune system to lose control and to develop what's called a cytokine release syndrome, where there is fever and drops in blood pressure and a dramatic decline in ability to breathe because of inflammation within the lungs. So some of our immunotherapies can also do that. When they go out of control, they can cause the immune system to overreact. And we actually have therapies to dampen that immune response. So while at the beginning of the viral infection, you want to stimulate the immune system, when people are quite ill from it and in the ICU, you want to turn down the immune system with some of the drugs that we have to do that. So that's another parallel.
Mm-hmm. Okay. Go ahead, Dr. Zagopoulos.
I would also add that the immune system, or the innate immune system that has been that is used to fight this virus, is also different across the lifespan. So the innate immune system in children is different than that in the older population, and sort of reflects what we're seeing in terms of who are the folks that get the sickest when they get infected with this virus. And the same could be said about cancer patients. Dr. Park talked about vaccines and developing vaccines. We could develop vaccines that are specific for the coronavirus, and that takes a little bit of time to both develop the vaccine and then put it through the rigors of clinical trial before administrating it broadly. But there are also other types of vaccines that are not necessarily against the virus itself, but have been developed for other treatments. And we may be able to take advantage of that more earlier in the course of fighting this disease, and put it into clinical trial and eventually make it broadly available for herd immunity, because that's essentially what we'll need in the end to beat this, or win this fight. So there are trials with the BCG vaccine that are going on around the world, and similar concepts are being developed here in Canada now.
Mm-hmm. So that's actually a good segue to my next question. I did want to bring up the issue of clinical trials, and I know in both of your cases, both of our doctors, you're obviously involved in that. In clinical trials, we know play a crucial role in cancer research and in helping scientists test out and measure the effectiveness of various new drug therapies before they can be rolled out to larger numbers of patients. So maybe I'll stick with you, Dr. Zagopoulos, for a minute. Why are clinical trials such an important part of any research into drug therapies? And what specifically are researchers looking for during these clinical trials?
So in some cases, and in the case of the cancer that I deal with the most, pancreatic cancer, clinical trial is the best form of therapy. Some of these aggressive cancers, we do not have very effective drugs. And where there is clinical trial, we try to put our patients on clinical trial, because that is the best form of therapy. There's a lot of concern that clinical trials have been suspended. And although the initial reaction may have been to stop and suspend all clinical trials, that is not what's happening. Therapeutic trials where there is value for the patient, there's clear benefit over standard of care, continue to happen. And in fact, there is also effort to open new clinical trials that we are on the verge of trying to open, where we believe there is benefit to the patient, a lot more value to the patient than standard of care. So as we continue our fight against COVID, we also have to keep in mind that we have to continue forward in our global fight against cancer, and that is not necessarily opening up trials only that only target COVID or have a COVID component to it. We must continue and try to see during these times how we could continue to open these cancer, therapeutic cancer trials to patients. What has come to a halt, unfortunately, are trials that involve observational protocols where the patient may have their tumor, for example, biopsied and sequenced to try to find a specific target. Those have been put by and large in most centers to a halt for now until we flatten the curve and are able to ramp up our clinical trial activities as a whole.
Mm-hmm. I guess that's I imagine that's partly because of practicing social and physical distancing, and also not putting cancer patients who are already at a heightened immune risk of perhaps getting infected. Correct?
Yes, it is. It's not only to protect the healthcare workers and the folks in the labs, but the patients themselves, and not to put patients through potential procedures and visits to the hospital where there is more uncertainty whether they'll derive a benefit from the intervention.
Okay. Dr. Assouline, I'm curious to know what is the status of clinical trials in oncology at the Jewish General Hospital? How many are still active? And what did you and your colleagues do once you realized that your expertise around clinical trials might be of better use in service of COVID-19 research?
Okay, so I just want to add something to what George said. While all observational studies are closed, we are opening registries for patients with cancer and COVID. So there's a COVID Cancer Consortium, which is a large North American endeavor to collect information on patients with cancer who also have the coronavirus infection in order to better understand the risk to these patients and how best to manage them. There are some publications out there about patients with cancer and COVID, but they're quite limited in terms of patient numbers. So this will be hugely helpful. And the consortium's intention is really to provide periodic updates about the patients included in the registry. Mm-hmm. And there's the same effort for hematological malignancies.
Okay. Actually, I was going to get to that shortly, but maybe once we're on that subject, we can come back to the clinical trial piece. But so maybe you could talk a bit more about that. So obviously there are plans in place right now to track cancer patients who become infected with COVID-19. So how is that taking shape, and why is that so important in terms of future treatments for cancer patients, whether it be throughout the course of this pandemic or perhaps in other infectious disease outbreaks that we might experience in the future?
Right. Like I said, there's limited information now about whether patients with cancer are at much higher risk. And, when we say somebody with cancer, we're talking about an array of clinical situations, patients who are receiving active chemotherapy. And even within chemotherapy, there are more aggressive and less aggressive forms. There are people who have had cancer in previous years, but are no longer, cancer-free. Are they in the same risk category? We have people who don't get chemotherapy, they get oral targeted drugs. Is their risk the same? So there's a lot of things we just don't understand about this population. And, I get emails from patients all the time. I have, can I go to work? I know their situation. Can I go to work? And I don't have enough information to say to them, well, this is your risk and this is what you're looking at if you do work, etc. Right now, I tell people to stay home and be careful, more careful than the average person, but it would be useful to have more specific information to inform the patients of what they're looking at specifically.
Mm-hmm. So let me jump back to the clinical trial piece, if that's all right. So what is the current situation at the Jewish General Hospital in terms of oncology clinical trials? And maybe you can share with us as well some of the efforts that you have made at the hospital to connect with infectious disease specialists and physicians in the ICU to try to bring some of that expertise to the COVID-19 fight right now.
Right. So I agree with George. As he said, the majority of our clinical efforts have come to a stop. And But the clinical trials that are essential to patients because they offer a benefit over standard of care have continued to enroll. But this still means that we have reduced the number of enrollments to clinical trials. And so that's largely what I do. And so in that context, I reached out to the ICU and the infectious disease physicians at my hospital who are involved in research, but not a lot of clinical trials. And I offered sort of our unit and our expertise to help them to build a portfolio of new therapies to treat COVID-19. And interestingly, some of the pharmaceutical companies that I work with and partners from across the country are developing clinical trials using oncology drugs to treat the infection. And they've come to me with proposals for clinical trials, which is something I never would have expected. But anyway, so I brought these clinical trials onto my infectious disease and ICU colleagues for consideration, and we are planning to open some of them at the Jewish. And I know there's a lot of effort at the MUHC also to open clinical trials to treat patients.
Mm-hmm. So when you first approached these physicians at the ICU and in infectious disease, were they puzzled by your outreach, or were they receptive to the offer and working with you?
Yeah, well, a little bit puzzled, but we have to work together for this. I mean, COVID-19 has changed how all of us function, and we've become much more of I'd say a team or a family, or an understanding that we all have to work together to treat this infection. There are surgeons and all kind of people, dermatologists, all kinds of specialists who never thought they'd be back on the ward managing patients, who are up there now taking care of patients with COVID-19. And I thought my contribution could be through the development of clinical trials, since that's what I know how to do.
Mm-hmm. Now, Professor Park, I'm just curious, what is the cancer researcher to do during all this, in the sense that how closely are you and your team and researchers at the GCRC and elsewhere following what's going on with COVID-19 research? Is there anything in particular that you find fascinating, or that you're sort of paying close attention to, that you might then want to take back to your laboratories once activity is back to normal?
Right. I think there's two things. One, I'll just follow up on something that Sarit and George were saying, which is the importance of being part of larger networks to capture the data about cancer patients with COVID-19. And as part of this, what we've established in Quebec is a Quebec Cancer Consortium that George and Sarit are both part of. And this is a consortium with the major cancer hospitals across Montreal and stemming out into Quebec and other cities in Quebec. The importance here is that we can then build these cancer clinical trials, just as Sarit was indicating, but we can transfer them to different sites very rapidly. And it's not just that we're building this as a network in Quebec. There's now a network across the country that's now supported by the federal government, called the Marathon of Hope, where the goal is to join up these cancer networks across the country, again, to disseminate rapidly the information that we learn in each of the centers. So this is both networking at the clinical research domain, but this also feeds back into the research questions that we ask in centers like the Goodman Cancer Center, because the Goodman Center is part of these networks and takes the leadership role in some of the networks. And one example I can give you is that in the center, we've really developed technology to look at the complex immune responses that occur in patients as they're being treated with immunotherapy type drugs. And our questions are, why do some patients respond to these immunotherapy drugs, yet others fail to respond? And also an important question, for example, is why do some patients then develop this hyperactivated immune response that Sarit was describing that she sees in the clinic? So we see this after patients are treated with immunotherapy type drugs, but we're also seeing it in some of the individuals who develop COVID-19 adverse symptoms. And so because of this, we've set up technologies that allow us to really look at this complex response. And these technologies can actually be used to look at patients with COVID-19. Why do some individuals have an adverse response and a hyperactivated immune response, whereas others don't? And so these will be key questions linked with the clinic, of course, to really begin to understand how we respond to these, to both cancer, but also COVID-19.
Thank you. I know it's still early days, but are there any cancer drugs that are being used in some of the COVID-19 trials or research that might show promise in terms of being helpful to treat patients infected with COVID-19? And what sorts of drug properties might be useful for both diseases or translational from cancer to COVID?
So I think Sarit, who's really running the clinical trials, should address, and she already raised some of these possibilities. There are many what we call immune checkpoint therapies in the clinic by multiple different pharma. Some of these, as Sarit describes, stimulate the immune response to cancer, whereas others are now actually coming into the clinic to dampen when some patients develop this overactive immune response. And I think Sarit described quite nicely, how important these could be to use with patients that have COVID-19.
You want to jump in, Dr. Escalini?
Yeah, sure. So that's exactly right. One of the drugs that has been used a lot for COVID-19 is tocilizumab, which is a drug that dampens the IL-6 cytokine-related toxicities of immunotherapies, but also of COVID-19. And so this is a drug that we use when our immunotherapies kind of go out of control. And now we're developing a clinical trial, hopefully for Quebec, to test tocilizumab in patients in the ICU. And there are many other trials of the drug going on, both in Canada and across the world. So that's one example. Another example is a drug called Ruxolitinib, which is an oral therapy used for myelofibrosis. Myelofibrosis is a blood disorder that results in bone marrow dysfunction, but it's associated with a lot of cytokine or inflammatory responses, including fever, weight loss, poor appetite, night sweats. And Ruxolitinib dampens the immune response through inhibition of JAK2 anyway. And so this too is a drug that's being tested by Novartis, but also here in Canada through a trial from Princess Margaret Hospital, which is a cancer hospital, in patients with COVID-19 infection. And there are other examples of drugs that, span the world, the world between infectious diseases and cancer. One of them is Lirenlimab, which inhibits the entry of the virus into the cells of the immune system, but is also being tested for metastatic breast cancer and for the treatment of HIV. So as you can see, there's overlap between treatment of viruses and treatment of cancer.
Great. So I do have a few more questions, which I want to get to, but let me just jump in with a couple more that have come in from our alumni. Again, they tend to be very specific. So I know you're not going to be able to offer much in the way of specific guidance or guidelines, but maybe you could offer some sort of high-level reassurance, perhaps, or address some of these. So the first one came in from a woman who says, "I am a year and a half out of bilateral breast cancer. I am now on tamoxifen. Is my immune system compromised due to this medication?" Anybody want to jump in on that one?
So I'll let Sarit answer that. She's an oncologist, but I would say a lot of these are good questions with answers unknown. But I'll let Sarit jump into that.
Yes, I agree with George. Unfortunately, there's not a lot of information out there to answer that question. This is why we have these registries, and this is why we need real-time results from the registries to be better able to answer that question. This person who wrote the question is in a very common situation. We have many patients who have had breast surgery and are on tamoxifen, and I would love to give a clear answer, but at this time I would just say that she needs to take the same precautions as everybody with social distancing and to protect herself.
Okay.
I think I could maybe add something there, that tamoxifen has been used for many years in the clinic. And obviously these patients are followed over time. So there's not any strong evidence that this would act in an immunosuppressive type manner. So again, depending on their health, this may not affect the immune response.
Okay. Let me try one more on the same vein. This one is from a 58-year-old male who says he was recently underwent high-intensity radiation therapy for prostate cancer. He's also in his 50th year of having type 1 diabetes, and due to an accident, lost 20% of his right lung because of a pulmonary embolism. His question is, if he gets COVID-19, will he be at any greater risk for complications?
So the short answer to that is the more health issues we have, the higher our risk is in terms of our fight against COVID if we become infected. And the specifics to this individual's health risks are hard to sum up and give them a risk score. But I would say that we should listen to our charismatic public health officer, Dr. Arruda, and practice what he's been saying every day. And earlier, I did not, I missed the opportunity to say that patients that are waiting for surgery should really stay home and protect themselves. So when that phone call comes for surgery, you will be in top health to have your surgery done and not be delayed further. And Sarit, I think you would say the same thing for your cancer patients under medical treatment, should practice those safety measures.
Yes, absolutely.
Okay. So on that same note, let me end with two more questions from alumni. I'll sort of bunch them together because they sort of get at the same theme. One was from a 65-year-old woman and two-time breast cancer patient, 2012 and 2016, is asking if she will still be able to have her appointment with her oncologist at St. Mary's Hospital in 2 weeks. And then a second audience member said she has chronic leukemia and has a dilemma. Should she come in for her appointment in May and risk coronavirus, or postpone the appointment? And if so, for how long?
So I can answer those questions. So for the person who has the appointment, if St. Mary's is like the other hospitals in the city, I think that the physician will reach out to her or the secretary to determine whether they should have their appointment, and then hopefully the physician will also speak with her and see if it's necessary for her to come in or if the visit can be done by telephone. Like I said, many of our visits are being done virtually now, and it seems to be working out okay. Similarly, for the patient with the chronic leukemia, I don't know the exact circumstances of her current condition, but I would expect that the physician will reach out, ask her how she's doing, and then make a decision as to whether it's mandatory for her to come in for a blood test. But we are aware that we need to call our patients and we need to organize their care. So if you haven't heard from anyone yet, it doesn't mean you won't. It's just that we have to get from list to list and week to week as the days move forward.
Right. And I guess the main message here, obviously, is if you're in a situation like this of uncertainty, don't just show up at the hospital. If you haven't heard, probably a good idea to call ahead and see if they're still operating and still feel that your case warrants a visit to the hospital, correct?
Yeah, absolutely. Do not show up. It's going to be difficult. Yes. Call first.
Okay.
I would also say, Derek, that for some of these follow-up visits where the patients need to have imaging done, come into hospital to have a CT scan, an MRI, an ultrasound, we are making some decisions to delay those tests and minimize the number of trips patients make to hospitals. And that is putting their safety first against COVID-19. But those are patients, for the most part, that have been out from their cancer treatment for some time, and we feel delaying for a couple of months is safe from a cancer surveillance point of view.
Yeah.
Mm-hmm. So I'm curious, actually, you brought up an interesting point, and I'll sort of maybe put this back to the two physicians. You've talked a lot about how cancer care and treatment has changed so much in the last 6 weeks because of the pandemic. I'm wondering if this is, in the longer term, going to force either of you or hospitals and physicians in general to perhaps rethink or revisit how care is administered in ways that actually might become a new normal once the worst of the pandemic is over? Dr.
Yeah,
Assouline?
it's a very good question. I've been thinking about that, and I see that we need infection control measures in our oncology clinics. I don't know how it is at the MUHC, but I would imagine it's not very different from the Jewish, where we have very crowded waiting rooms, we have lineups for blood tests, and these are all opportunities for transmission of virus. So as we move forward, we're going to have to figure out how to properly organize our clinics so that we can ensure the safety of our patients while they wait to see the physicians. George, what do you think?
I think we'll learn a lot from this. I think man's greatest discoveries have happened with unplanned experiments and unfortunate circumstances. We'll learn a lot, both from how, what the impacts are with certain types of cancer treatments in patients that unfortunately develop COVID, with some of the delays that we're forced to put in place in some treatments and surgeries. And I think it will also force us to rethink how we assess and deliver care. I think this emphasizes the need for better telehealth infrastructure or video health infrastructure in the province of Quebec, a province that is not accessible by many, especially those that live up in the north. So this is a call to the government to think beyond COVID-19 and into the future, and maybe this is a wake-up call for us to put those in place. Mm-hmm. And finally, I would say that it's, as Sarit has done, is taking tremendous leadership in this, is bringing new research units together. So redeploying for now, but hopefully these new relationships will connect people in different ways, and we'll see ID docs working closer with cancer docs, and new innovations will come. And I think, it's hard to be positive in these times, but if I were to be positive in one way, I think it's connected some of us together where we would not have otherwise been connected.
Mm-hmm. Interesting. So I do want to end on a positive note. So let me sort of maybe circle back to some of the data I threw out at the beginning of this broadcast. We mentioned some very troubling numbers, that 88,000 Canadians are likely to die of cancer every year, which is almost 250 every day. Some might argue that those statistics can be described as pandemic-like numbers. So Professor Park, maybe I'll turn to you here. Obviously, the world's attention right now is diverted away from cancer research at the moment, and your labs have been shuttered for the most part. But in the longer run, do you think that the reach and significance of this pandemic and the renewed attention it is putting on the importance of science and research might end up being a blessing for cancer research programs? Or in other words, has the scare that we're going through right now woken the world up to the struggles we face every day to eradicate illnesses and disease, be it smallpox, polio, malaria, tuberculosis, or of course, all the various forms of cancer?
Yeah, I think that's a really good point. What's clear to us is that cancer, just like COVID-19, has no boundaries. But what's also clear to us is that research over the last 60 years, because of this, we know that we will make a vaccine or multiple vaccines to COVID-19. We'll have better diagnostic tests. We'll have better tests to detect the virus earlier in the population. This is all based on research. And with cancer, it's the same. Research is really driving new discoveries. From research, we now recognize the importance of research to both either try and prevent cancer, but importantly to detect it at earlier stage so that we can treat it more appropriately. Some of our biggest questions now, though, are those cancer patients that don't respond to standard of care or the new immunotherapies. And these are the questions that we have to ask. These are our big, why don't they respond? And these are the challenges that we're facing. But I think with the understanding of the importance of research in COVID-19, the world has really changed how it comes together. Researchers internationally are sharing data to work on COVID-19, to make the discoveries go faster for vaccines. And I would say, just like COVID-19, you know, cancer researchers at McGill and are working internationally, with collaborating with others nationally and internationally to really speed up how discoveries are transferred. I mentioned earlier about these clinical trial networks, both in Quebec and across Canada, that are being developed. And the goal there is to really translate research discoveries rapidly to the clinic, to clinical trials, such as the trials that Sarit is conducting, and to share this across Canada. And this recognition of the importance of research is really fundamental to our understanding of how we make discoveries and how we bring new therapies to the clinic.
Okay, well, very well said. Yeah, go ahead, Dr. Zagopoulos.
I just wanted to add that in cancer research, we often focus on finding discovery to how to better treat the cancer. And what this has forced me to think about deeper is our efforts in cancer prevention and early diagnosis. How better to address all of the anxiety our viewers have than to be able to reassure them that we have better cancer prevention mechanisms. So the fewer patients we have with cancer, the less of an impact pandemics like COVID-19 would have. So our efforts are towards finding a vaccine and preventing COVID-19. I think it's important not to lose sight that we need to have efforts towards preventing cancer, surveillance, early detection programs across all cancers, including those that carry a risk that is passed on to them from generation to generation through genetic risk factors and genetic predisposition. So I think this is another call to us to make sure that we focus on cancer prevention and early detection as well, not just treatment.
Okay. Dr. Assouline, you want to try to match any of the eloquence of your fellow panelists?
Excellent, really. I'm not sure that I can. Those were excellent statements and very inspiring. I would just say that, you know, to reassure our patients who do have cancer and don't have COVID-19, you know, you remain our priority, which is to ensure that despite everything that's going on around this virus, we know, and we haven't lost sight, that you know, your survival, your well-being, your safety are primary to us. And that's how we look at
Great. Well, I'm not sure we could have ended on any more optimistic or reassuring words than that. So thank you all for those closing statements. That, of course, does wrap up the time we do have today. Before we close, I would like to remind you that this video will be available at this very same link soon after our recording ends. So feel free to share it with others who may not have been able to tune in live. And please keep watching your email and social media feeds for more information about how McGill is confronting the challenges of COVID-19 and cancer and so many other diseases, as we keep you informed with insight from our academic and medical experts. I also want to report on some exciting news from McGill. Those of you who tune in regularly will often hear me mention the McGill Student Emergency Support Fund. I'm pleased to let you know today that the community has rallied together to raise more than $650,000 so far. When paired with the monies contributed by the university, there's now just over $1 million available to McGill's Scholarships and Student Aid Office to distribute to McGill students in need of financial relief because of the COVID-19 pandemic. You can find out more information at giving.mcgill.ca. That's giving.mcgill.ca. And finally, I'd like to extend a sincere thank you to our three guests, Morag Park, George Zagopoulos, and Sarit Assouline, for taking time out of their very busy schedules to join us today and for providing us with such important information about cancer and our health and well-being more generally. It is much appreciated during these challenging times. And thank you, McGill alumni, for tuning in today. Next week, we'll be pulling double duty in the advancement office with 2 webcasts on the schedule. On Tuesday, we'll be sitting down with McGill experts in aging and geriatric medicine to look at one of the most devastating aspects of this pandemic, which is the plight of the elderly. We'll also hear from a caregiver who will offer guidance and tips for those of us who find ourselves in the position of caring for older loved ones. And then I'll be back here again at the usual time on Thursday as we look at the history of pandemics through the eyes of a McGill history professor who has studied cholera, smallpox, and the Spanish flu, and a scientist who came of age as a researcher during the HIV/AIDS epidemic and is now on the front lines of COVID-19 research right here at McGill. That promises to be a fascinating discussion. On behalf of all of us at McGill's Office of University Advancement, please stay home, stay safe, and be well, and see you next week. Thank you.
Thank you.
Thanks, Derek.